syndesmosis mostly is fixed by ST2 or ST3 students unless it is a periarticular complex. This X-ray was brought to me by one of the patient, young girl, 20 to 25 years of age. I just kept looking at it. I was thinking, oh yeah, there is some arthritis, medial clear space distorted. What then transpired was she has undergone some 5 or 6 surgeries, and although she was just 24 years of age. And in fact, they have even attempted fusion also. If you can see from the talus, there is a screw which is going down towards the middle malleus. So there were some previous X-rays also, a lot of X-rays. I was very perturbed. For the sake of brevity, I have not uploaded the MRI, but even her subtalar joint was also very badly losing cartilage. And that was her subtalar and the ankle joint. Any suggestions from the house for managing this young lady's ankle? Anyone?
Inflammatory?
Sorry?
Is it post-inflammatory? Any history?
No. CBC, ESR, CRP was fine. Definite history of trauma. First they put on a plaster for a few days and 3-4 surgeries after that.
3-4 surgeries?
Yeah. Very painful, very difficult to walk.
Avascular necrosis of the talus.
Yeah. It's very painful as well. Yes. Because the doubt was, shall I be fusing in such a young patient? I am not a great fan of ankle joint replacement at such young age. I have got some limited experience with the star ankle joint replacement. Although nowadays they are claiming 90% success rate and almost matching a unicondylar knee. So I went for a classical TTC fusion nail. Any other particular preference over this? There is an anterior plate, screws, interfragmentary. Anyone would like to comment, sir? Yeah, it's a subtle, channelless type of fixator, yes.
You can use
and you do the fibula excision also, sir, for that?
I don't think so. It's necessary to do a fibula. If you get a very good surface for union, no need of taking out the fibula.
All right, that's good. Okay. Because
or if it is there, then you can take a part of fibula and put from tibia to talus and then put a fixator like that also.
Exactly. So that is what you can see over there. There is a fibula used as a biological plate over here. This young lady was almost into some psychological issues. So 1 year I waited, or 6-8 months, she was fine. That's her X-ray. Then I did a CT. I was wondering why she was having pain. But CT was not very helpful with this much of the metal work lying in it. So this is the X-ray which I have taken in the operation table. By the grace of God, her joints have fused and I have taken out. So the whole idea of presenting this was, you should take, especially the young surgeons, ankle joint and syndesmosis very seriously. How do you classify? I am quite happy with the Weber's classification because type C1, C2 or sometimes in B, you will get a syndesmotic injury. Log-Hansen's genetic classification is very anatomical and in great detail, but there is, when a study was presented to 40 ankle and foot surgeon, I am not talking about any surgeon, there was no congruence on which classification to be applied to some of the X-rays, almost 40% of that. We generally tend to fix them. That is a classical approach and we go ahead with that. There are some efficandos of tight ropes also, but I think I have gone more towards the screw fixation. Syndesmotic joint is not a joint which you can play around. In difficult cases like in revision, you can get along with multiple screws, but then it will lead to arthritis. So little bit of mobility at syndesmotic joint is paramount. Talocrural angle is very important for making an assessment. Generally, it should be the intermalleolar perpendicular line to the plafond and 15 degrees angle or 82 degree angle is good enough for judgment. Middle clear space should not be more than 5 to 5 millimeter. And if even 1 millimeter shift of the articular surface causes 40% decrease in the contact surface area and severe point loading. Those who have done studies of the cartilage in the hip and the knee will know that the cartilage is thinnest in the ankle, although one would have thought contrary. So you have to be very careful about how you are reducing it. Weber's classification we use, mostly it is B and C, and please be aware of the process of the talus fractures and metatarsal fracture which might have, and syndesmotic injury, because you can see tibia is rotating internally and fibula outwards, which will lead to the disruption just like a sacroiliac joint, anterior, middle and lastly posterior. So these are the tests: syndesmotic tenderness, squeeze test, squeeze in the calf will elicit pain. This is the chronic syndesmotic injury. You generally get along well with the ankle fractures, but one such young guy, college student, actively is participating in the sports, and he will come off complaining of the pain, and you will find that if you do CT, 50% of the syndesmotic injuries are mal-reduced. Another is external rotation stress test and the cotton test, which we routinely do during our pre-op cases as well. There should be 4 to 5 overlap in the normal view and 1 degree on the mortise view. That is a classical lambda sign where the fluid has gone in between the tibia and the fibula. Now, in 2010, there were a great number of cases and paper being published in JBJS about the ankle syndesmosis, and some studies were the cadaveric studies where they have taken out the fibula from the neck or some above the knee. And at one point, I thought some of the things are going to change the clinical practice. One was the intraoperative CT for the fixation. We used to take the CT for the opposite limb also. This CT we used to take just 1 millimeter above the plafond, and just to mark the anterior part of the incisura, fibula, and how much translation is there. Because the criticism was that when you put on a patellar clamp in full dorsiflexion, fibula tends to external rotate. Although CT showed 55% of the cases were fixed in external rotation, but even in spite of using an intraoperative CT, the incident just came down to 10%. Then we got CMOS, navigation. Recently robotics has also been tried, but I am not including it because it has not been proven. CMOS is good, but still the result has been down only up to 7.5%, as you will see later. Conservative is only for syndesmotic sprains. 2 screws, 1 screws, where to place, 3 cortex, 4 cortex is everybody's personal preference. This is a classical way of fixing it. Fix the bone, repair the ligament on the medial side only if it is required. That is a classical conventional approach for the ankle. Chaput fracture. Generally very difficult to fix when they are small. Large fractures can be fixed. Generally the anterior part is mostly shredded. So this is same. 16% detected on the plain radiographs and 52% on the CTs. But in spite of using CT intraoperatively, we have not been able to achieve or eliminate that mal-reduction of the syndesmotic injuries. This is a type of posterior fracture which we tend to, at least I tend to ignore. Just do a dorsiflexion and we'll assume that the fracture will fall into the place because it is only 20% of it. But now that is a classical thinking which has gone up with the recent thing. What is this anatomical approach? What they think is anterior tibiofibular ligament, inferior tibiofibular ligament is almost shredded, just like sacroiliac joint opens from anterior to posterior. Chapu fracture, if it is quite big, you should try to attempt to fix it. Middle fragment is next to impossible, but it is a posterior fragment which you can fix. And the classical way is, it's a big periosteal sleeve. So if you go back to the previous slide, in this fragment, you don't need to fix it. You can just use a screw or a washer. Sometimes people use suture anchors also to fix the posterior inferior tibiofibular ligament, and then the reduction has become much better. So direct repair of the AITFL and PIFTFL is indicated. It is usually available at the tibial insertion, and there are detailed papers explaining how to fix this one. Again, anterior inferior tibiofibular ligament generally can be repaired, and technically it is very difficult. Reconstruction is much better, but that is seldom practiced nowadays. What is the benefit of so-called this anatomic report? Improvement of syndesmotic reduction. So what is this improvement? Mal reduction from 33% to 7.4%. That's why ultimately the conclusion, which is evidence-based medicine, is CT scan, navigation and robotics. They are very good, but they don't altogether eliminate the maldetection. So the classical treatment of putting on a screw with 30 degrees hand dropping down, using 3 or 4 cortex, maybe including just above the scar mark of the epiphyseal scar, it still holds true. Take home points. Accurate syndesmotic fixation is a predictor of good functional outcomes in ankle fracture. How would you do that? Make sure that the medial clear space is maintained. There is no tibial shortening and external rotation. Transsyndrotic screws are often associated with maldetection of the ankle injuries and subsequent clinical problems. So use these features that will really help you in a clinical practice. CT scanning is essential. Maybe you can try it as a pre-op, but there is no evidence to suggest that intraoperative CT, navigation, robotics is coming up, but there is still no conclusive proof that it makes a huge difference. It just reduces the incidence of maldetection. Posterior malleolus fracture fixation, even though it is less than 20%, is something to look about, but then you might need to change the position, and there is an excessive morbidity with the second scar mostly. Chapu fracture, if they are big enough, they should be fixed. I think that's all about syndesmotic injury. Thank you so much.